Okay, imagine this scenario. You're the main caregiver for your mother. She's 75, she's frail, and she just tested positive for COVID-19.
It's the news you've been dreading.
Exactly, for years. And you're immediately worried about her lungs, her breathing, the classic scary symptoms. But then maybe 3 or 4 days in, something else happens.
Right.
She isn't coughing. Instead, she gets this severe, uncontrollable diarrhea. She's weak, lethargic, a little confused. And when you look over at the kitchen counter, you see this whole stack of pill bottles.
Mm-hmm.
And you realize she's taking 4 different medications, all prescribed by well-meaning professionals that all list diarrhea as a major side effect.
It is a terrifying situation, and honestly, it's far more common than most people realize.
Yeah.
It's a textbook example of what we call a prescribing cascade.
A prescribing cascade. That sounds, well, given the symptoms, it's a terrible metaphor, but it sounds ominous.
It is ominous. A prescribing cascade is when a patient takes a drug, gets a side effect, and then instead of stopping that first drug, a doctor prescribes another drug to treat the side effect.
Oh, wow.
And then that drug has a side effect, so they get a third drug. But in the case we're looking at today, in this deep dive, it's actually even worse. It's what our sources call a perfect storm.
A perfect storm.
It's multiple medications, all prescribed at once, that are just fighting against her body's ability to stay hydrated.
So today, we are unpacking a doctor discussion guide. And this isn't, general medical trivia. This is a tactical guide for a caregiver who is walking into an urgent medical appointment and needs to know exactly what to say.
Exactly.
We've got a stack of sources here: medical advocacy guides, drug interaction sheets for Paxlovid, safety warnings. And our mission is to figure out how to advocate for a patient who is, you could argue, suffering more from the treatment than the virus.
That's the goal. The goal here is to distinguish between what is strictly necessary to keep her alive and fight the virus, and what is just adding to the noise. Or in this case, the dehydration.
Right.
Because in geriatrics, sometimes the best medicine is taking the medicine away.
Okay, so let's set the scene with the patient profile. She's 75, COVID positive. And her main symptom right now is not respiratory, it's excessive diarrhea. And the source material just flags this as a massive risk: dehydration. Now, I have to ask.
Yeah.
We've all had a stomach bug. It's miserable. But is it really life-threatening?
For you or me, probably not. We feel terrible for a day, drink some Gatorade, and, we bounce back.
Right.
For a 75-year-old, it is absolutely life-threatening.
Wow.
It really comes down to something called physiological reserve.
Physiological reserve. Okay, break that down for us.
Think of it like a backup tank. As we age, our bodies literally hold less water. Our thirst mechanism, that little signal that tells your brain, hey, drink something, it gets weaker.
So an older body is already starting closer to the edge.
Exactly, closer to the edge of the cliff. So when you add this excessive fluid loss from diarrhea, you're not just losing water, you're losing electrolytes, potassium, sodium. And when those get out of whack, the heart's electrical system can fail.
But the guide flags something even more immediate than the heart, right? Talks about the kidneys.
Acute kidney injury. This is the immediate danger. Your kidneys are like a filtration plant. They need a certain amount of water pressure to work. If the fluid volume of your blood drops too low from the diarrhea, the kidneys just can't filter.
So they just shut down.
They basically shut down to preserve fluid for the brain. And in an older adult, this can go from mom is thirsty to mom is in renal failure in a matter of hours, not days.
Hours? Wow. So the clock is ticking loud. And yet she's on this cocktail of drugs. Okay, let's read the list from the case study. She's taking amoxiclav, an antibiotic,
Right.
fluconazole, an antifungal, Paxlovid, the antiviral for COVID, and Reglan, also known as metoclopramide for gastric motility.
When I first saw this file, I actually had to double check that it was real. Because every single one of those drugs, independently, attacks the gut. Putting them all together, it's like chemical warfare on her digestive system.
Okay, let's unpack this drug by drug. I want to start with the antibiotic, amoxiclav. I feel like everyone's taken amoxicillin at some point. It feels so safe.
It feels familiar, sure. But amoxiclav is a combination drug. It's amoxicillin plus clavulanic. And that second ingredient makes it what we call a broad-spectrum antibiotic.
Meaning it kills a wide range of bacteria.
Right, but broad-spectrum is just kind of a nice way of saying scorched earth.
Scorched earth.
It doesn't discriminate. It kills the bad bacteria, but it also just wipes out your microbiome, all the good bacteria in your gut that keeps your digestion solid.
Okay.
The sources note that about 1 in 8 people taking amoxiclav will get diarrhea. But in the elderly, wiping out that good bacteria raises this huge red flag for something called C. difficile. C. diff.
I've heard of C. diff. That's the hospital superbug, right?
That's the one. It's an opportunistic bacteria that just hangs around waiting for an opening. So when amoxiclav kills off all the good guys in the gut, C. diff takes over. And it causes this severe, watery, colitis-level diarrhea.
So by giving the antibiotic, you might be inviting a new deadly infection that causes the very symptom you're trying to avoid.
Precisely. You're trying to avoid dehydration, and you're inviting a bug that causes it.
Okay, so that's strike one. Then we have fluconazole. That's for yeast infections. Why is a COVID patient taking yeast medication?
That is the million-dollar question.
Yeah.
And the guide questions this aggressively. Usually doctors prescribe it prophylactically.
Just in case.
Right, just in case. The thinking is, well, she's on antibiotics, so she might get a yeast infection, so let's just give her the antifungal now to prevent it.
It's proactive prescribing.
It is. But fluconazole is hard on the liver, and it's notorious for causing nausea and stomach upset. So you're adding a definite GI burden to prevent a theoretical yeast infection.
Strike two. Then there's Paxlovid. Now, we know this is the gold standard for COVID, but I have heard rumors about Paxlovid tummy.
It's more than a rumor. Paxlovid poop is a colloquial term for a very real reason. It's a known side effect. But honestly, the diarrhea from Paxlovid is the least of our worries compared to the drug interactions.
Which we'll get to.
Yes. But first I want to talk about that fourth drug, the Reglan.
Reglan, metoclopramide. The Thorse calls this one the gas pedal.
And that is the perfect analogy. Reglan is a prokinetic agent. Its job, its medical purpose, is to make your stomach empty faster and speed up intestinal transit.
Wait, let me get this straight.
Yeah.
She has excessive diarrhea. Everything is moving way too fast.
Right.
And they prescribed a drug that makes things move faster.
Precisely. It's completely counterintuitive. It's like seeing a car careening down a steep hill and deciding to just stomp on the accelerator.
So why would a doctor do that? I have to assume they aren't trying to hurt her.
Of course not. It's usually prescribed for nausea. COVID causes nausea. So a doctor sees a patient has nausea, writes a script for Reglan to help empty the stomach.
And doesn't connect the dots.
Doesn't connect the dots that the patient is also having diarrhea. Or maybe the diarrhea started after the Reglan. This is the definition of that prescribing cascade.
Right.
You treat the nausea with a drug that acts as a laxative.
And the source mentions a black box warning for Reglan too.
Yes, specifically for the elderly. It can cause something called tardive dyskinesia.
That sounds terrifying. What is it?
It's involuntary muscle movements. So twitching, grimacing, tongue movements, they can actually become permanent.
Permanent neurological damage.
Yes. So you're risking that to treat nausea in a patient who is currently dehydrating to death from the treatment itself.
That is just, it's wild. So the action plan in our source guide focuses on deprescribing. It actually gives the caregiver a script.
And I love this script. It really empowers the caregiver to step out of that passive role. It suggests asking something like, given her excessive diarrhea, is it strictly necessary to continue amoxiclav or fluconazole if an infection hasn't been confirmed?
And then specifically for the Reglan.
For the Reglan. Should we pause this immediately since it speeds up digestion?
So it's about stripping it all back to the bare essentials, but that leads to the next big question. If we stop the antibiotic, the amoxiclav, aren't we risking pneumonia?
Yes.
I mean, she has COVID. Pneumonia is the big fear. If I'm a caregiver, I am terrified to stop the pneumonia drug.
And this is where it gets really interesting, where we have to clear up a massive misconception.
Yeah.
We need to distinguish between viral pneumonia and bacterial pneumonia.
Right. COVID is a virus.
Correct.
Yeah.
COVID-19 causes viral pneumonia. Antibiotics like amoxiclav kill bacteria. They do absolutely nothing to a virus. Nothing.
It's the wrong tool.
It's like trying to put out a fire with a hammer.
Yeah.
It's the wrong tool entirely.
So why was she even prescribed the antibiotic in the first place?
Fear. It's just in case medicine. The doctor worries that there might be a secondary bacterial infection piggybacking on the COVID. And it happens, but it's not a guarantee.
And the risk outweighs the reward here.
Exactly. The source material emphasizes that without proof, the risk of the antibiotic destroying her gut is much greater than the benefit of treating a theoretical bacteria that might not even be there.
Okay, so this brings us to the hidden danger mentioned in our outline. Silent pneumonia. Can you define that for us?
Silent pneumonia or silent hypoxia is it's spooky. Usually if your oxygen drops, your body panics, you gasp, you feel this air hunger because carbon dioxide is building up.
Right.
But with COVID, especially in seniors, the mechanism is different. Oxygen levels can drop dangerously low. We're talking into the 80s or 70s, and the patient just doesn't gasp.
They don't feel like they're suffocating.
No. They just look tired, maybe a little confused. They might seem out of it. That's why it's silent.
And that's why the antibiotic prescription is so dangerous here.
It gives a false sense of security. The caregiver thinks, oh good, we're treating the pneumonia with the pills. But no, you aren't. You're treating a bacteria that likely doesn't exist, while the virus is silently dropping her oxygen levels.
So the guide suggests a specific advocacy move here. It says to demand diagnostics.
Yes, strictly necessary diagnostics. Before you agree to continue this diarrhea-causing antibiotic, you ask for two things. One, a chest x-ray.
What's the x-ray going to show that the doctor doesn't already know?
It distinguishes the pattern. Viral COVID pneumonia looks like ground glass, sort of hazy white patches scattered around. Bacterial pneumonia usually looks like consolidation, a solid, dense white blob in one area.
And if it's ground glass?
The antibiotic is useless. Stop it. Save her guy.
And the second diagnostic.
Pulse oximeter. That will put you. The guide says the caregiver needs to ask, can we monitor her oxygen to rule out silent hypoxia? Because if her oxygen is fine and the x-ray is clear of bacteria, there is zero reason to be on that antibiotic.
It sounds so simple when you lay it out like that, but I can see how in the heat of the moment you do what the doctor says.
That's the power dynamic we're trying to shift here. The doctor is treating the COVID patient template. The caregiver, you, are protecting your mom who is dehydrating.
Yeah.
You have to be the one to ask the question.
Okay, so let's assume we've cleared the deck. We stopped the Reglan, we stopped the antibiotic because the x-ray was viral, not bacterial. We still have to treat the actual COVID, right? She's 75, high risk.
Absolutely. We're not saying don't treat, we're saying treat the right target. We need to eliminate the virus.
The source lists a few options: Paxlovid, Remdesivir, Molnupiravir. We touched on Paxlovid and the stomach issues, but the guide raises a much bigger red flag about interactions.
This is critical. Paxlovid is a miracle drug for many, but for a 75-year-old, it can be a minefield. See, Paxlovid contains two drugs, nirmatrelvir and ritonavir. And ritonavir is the problem child here.
Okay.
It is a potent inhibitor of an enzyme called CYP3A.
Okay, let's unpack that. CYP3A, it sounds like a droid name. What is it?
Think of CYP3A as the traffic cop in your liver. Its job is to direct traffic, to break down other medications and move them out of your system so they don't pile up.
And ritonavir?
Ritonavir ties that traffic cop up and throws him in the trunk. It just turns the whole system off.
So if you're taking other drugs while the traffic cop is missing...
They crash into each other, they build up, they don't get broken down, they can reach toxic levels in your blood.
What kind of drugs are we talking about here?
The exact drugs a 75-year-old is likely to be on. Statins for cholesterol, blood thinners like Eliquis or Xarelto, heart rhythm medications.
So if she's on a blood thinner and she takes Paxlovid...
She could essentially overdose on her blood thinner and bleed out internally. Or if she's on certain heart meds, she could go into a fatal arrhythmia.
Wow.
The source guide explicitly tells the caregiver to ask, if we consider Paxlovid, have we reviewed her other maintenance medications for interactions?
It's not enough to just prescribe it. You have to check the whole list.
And sometimes, doctors are in a rush, or they don't have the full list from the specialist. This is where the medical advocate saves lives. You have to be the one to say, wait, she takes simvastatin. Is that okay? And spoiler alert, it's usually not okay with Paxlovid.
Okay, so if Paxlovid is out, either because of the diarrhea risk or the heart meds, what are the alternatives? The guide mentions Remdesivir.
Remdesivir is a great option in this specific diarrhea storm scenario. It's an IV infusion.
4V, so it bypasses the stomach completely.
Exactly. It goes straight into the blood. It's much, much easier on the gut. It doesn't cause that severe diarrhea that Paxlovid can. And it has far fewer drug interactions. It doesn't inhibit that traffic cop enzyme.
What's the downside?
Logistics. Really. You have to go to an infusion center for 3 days. But if the alternative is kidney failure from dehydration at home, it's worth the trip.
And Molnupiravir, what's that one?
That's another oral pill. It has a lower efficacy than Paxlovid. It doesn't work quite as well, but it has a much cleaner side effect profile. No massive drug interactions. So it's often the backup for patients who just can't take Paxlovid.
So the ask for the doctor is basically, is she eligible for IV Remdesivir to save her gut?
Right. You're asking the doctor to prioritize her current vulnerability, which is her gut, and her hydration status, both convenient.
This is really empowering. I want to move to the red flags that actually work for this. because even with the best advocacy, things can go south fast. The guide has a checklist for when you start talking and you start dialing 911.
This is the safety net. You need to know the point of no return.
The first one is oxygen.
Right. If that pulse oximeter drops below 92%, or if it's just consistently dropping from the baseline. And also look at the patient. Blue lips, blue nail beds, that's cyanosis. It means the tissues are starving for oxygen. Call 911.
What about her mental status?
This is a huge one for both dehydration and silent hypoxia. Confusion. Delirium. If mom suddenly doesn't know where she is, or she's talking to people who aren't there.
Or she's just really out of it.
Extremely lethargic. You can't wake her up properly. That's not she's tired from COVID. That is her brain isn't getting oxygen or her electrolytes are crashing.
And the physical signs of dehydration?
Inability to stand. If she tries to get up and faints or gets incredibly dizzy, that's a sign of low fluid volume. And the big one, urine output.
The guide says no urine output for 8 to 12 hours.
That is the siren song of acute kidney injury. If the kidneys stop making urine, it means they have shut down to preserve fluid. That is a true medical emergency. You cannot fix that with Gatorade at home. You need IV fluids immediately.
And finally, pain.
Severe abdominal pain. This could mean the colon is severely infected. Remember that C, diff, risk, or compromised. And chest pain could be heart strain.
Okay, so let's synthesize this. What is the strictly necessary action plan for our listener? If you are walking into that doctor's office today, what are the 4 steps?
Step 1. Stop the accelerator. Ask to pause the Reglan. There's no logic in speeding up a gut that's already a fire hose.
Step 2.
Verify the infection. Don't accept just-in-case antibiotics. Ask for the chest x-ray. If it's not bacterial, stop the amoxiclav. Save her gut.
Step 3.
Review the antiviral. Don't just take the Paxlovid script. Check the interactions with her heart meds, her blood thinners, and ask about 5e remdesivir as a gut-sparing alternative.
And step 4, the most important one.
Prioritize hydration. The virus might kill her in 2 weeks, but dehydration will kill her in 2 days. If you can't keep fluids in her, you need to be in the ER.
It's such a shift in mindset. We're always told, take your meds. But here the message is prescribing.
Deprescribing is a legitimate medical intervention. In geriatrics, taking a medication away is often more powerful than adding a new one. When you have a 75-year-old body, that balance, homeostasis, it's fragile.
Right.
Every drug you throw in creates ripples. Sometimes you have to stop the ripples to let the boat stabilize.
It reminds me of that concept of treating the patient, not just the chart.
Exactly. The chart says COVID positive, so the algorithm says Paxlovid plus antibiotic plus symptom management. But the patient is a frail woman who is dehydrated. The algorithm doesn't see the dehydration until it's too late.
The caregiver sees it.
The caregiver sees it. That's why the role of the medical advocate is so vital.
It really is.
Doctors are experts in medicine, but you, the caregiver, are the expert on the patient. You know what she looked like yesterday. You know how much she's drinking. You are the only one who can connect the dots between the new pill and the new symptom.
And asking questions isn't being difficult.
No, it's being a part of the care team. Asking, is this side effect worse than the cure? Is maybe the most important question in medicine.
So what does this all mean for us, even if we aren't caring for a COVID patient right now?
It means we need to look at medication list with a critical eye. Just because a pill was prescribed doesn't mean it plays nice with the others. We have to look for that prescribing cascade. Did I get a pill to treat the side effect of the first pill?
And if the answer is yes, maybe it's time to ask about taking something away instead of just adding more.
Precisely. Less can be more, especially when more is a perfect storm of side effects.
Well, that is a lot to digest, pun intended. But hopefully it gives anyone in this situation a roadmap to safety.
It's about being brave enough to ask why, and, what if we don't?
What if we don't? I love that. We'll leave you with that thought. Are there meds in your own cabinet that are treating the ghost of a symptom that's long gone? Something to think about. Thanks for diving deep with us.
Stay curious and stay safe.